Hello, my name is Dr. Alice Hyun-Kyung Tan, and welcome to my lecture on COVID-19 in Korea. I'm an internist in Seoul, South Korea, and I regularly broadcast on current health issues. Today's topic is COVID-19 and Korea's response to this public health crisis. Before I begin, I'd like to thank Professor Woo Jung-yup for inviting me to give this presentation as part of the Ministry of Foreign Affairs Fulbright Scholars Lecture Series. The story of South Korea's battle against COVID-19 has drawn the attention of many around the world. Today, I'll start with a description of both the virus and the disease, because the basic knowledge of the virus and the disease will help you understand why the infectious disease control measures were implemented and why they worked. Then I will move on to an explanation of South Korea's response to COVID-19, how we crushed the curve. So let's take a look at this wily killer, SARS-CoV-2. SARS-CoV-2 stands for Severe Acute Respiratory Syndrome Coronavirus 2. It is in the family of coronaviruses, which include the causes of the common cold and also other zoonotic coronaviruses that have caused epidemics in the last 20 years, SARS and MERS. When we analyze the genetic code of SARS-CoV-2, we can identify it as a new virus in humans and one that is closely related to SARS-CoV. Zoonotic means that the natural host of this virus is an animal, most likely a bat. We think that it first infected a human through an intermediate host vector. The most recent data implicate the pangolin, which is a type of anteater, but researchers are still trying to find the definitive source. This is a drawing of the virus. I would like to point out that generally viruses cannot survive for long, nor can they replicate or multiply without a host. The SARS-CoV-2 has glycoprotein spikes that latch onto a protein receptor called the ACE2 receptor. These receptors are located on alveolar cells deep within the lung. This explains why the main problem manifests as pneumonia, and there are fewer upper respiratory tract symptoms, such as sore throat or nasal symptoms. Another feature that I want to point out is that the virus has a membrane and envelope that is made of lipid or fat. So when you wash your hands with soap and water, the soap breaks the virus open and causes it to die. Here is a diagram showing how the virus enters the lung cell, replicates, and then exits the cell to spread within the body. When the virus travels back up the windpipe and out of the body every time a person talks, coughs, or sneezes, then it could spread to its next host. Also in this diagram are the potential drugs to treat COVID-19 and their targets. The most promising agent so far seems to be remdesivir, an experimental antiviral medicine that inhibits RNA-dependent RNA polymerase. However, I should mention that there is yet no proven cure for COVID-19. Now, let's take a look at what we know about the disease. COVID-19, which stands for Coronavirus Disease 2019. The most vexing part of this disease is that anywhere from 18 to nearly 50% of people who are infected may not have symptoms or may have very mild symptoms so that they are not aware that they are sick. But, and this is very important, they can still spread the virus onto others. This is why drastic measures such as lockdown needed to take place in cities where the virus had already circulated widely in the community. Without widespread testing, it is impossible to confidently separate infected from non-infected persons. The other symptoms overlap with other acute respiratory illnesses, such as fever, weakness, cough, and achiness. But as I mentioned, it is primarily a lower respiratory illness. So chest pain and shortness of breath have been reported, but there is less sore throat, nasal congestion, or runny nose compared to a cold or flu. Also, it has been noted that a loss of smell and taste can be one of the early symptoms of COVID-19. The latent period, which is the time it takes to develop symptoms after getting infected, is anywhere from as early as 1 to as late as 27 days. But on average, it is 3 to 6 days, and most people who get symptoms will start to experience them within 14 days. Thus, the self-quarantine period is set at 2 weeks. One fortunate aspect of the illness is that the vast majority of infected people, about 80%, will have mild or moderate illness and will recover without the need for serious intervention. In other words, many positive cases will not need to be hospitalized, only isolated. That is why Korea prepared 4,000 beds to isolate patients with mild symptoms. About 20% of cases will have severe or critical disease. And in Korea, sadly, 2.2% of cases, 238 people so far, including one doctor, have died. Although our country's case fatality ratio is on the lower end of the spectrum, each death was the loss of a precious life, a precious family member, a tragedy, and the entire country grieves for those who have died due to COVID-19. We now know that viral shedding can start as early as 2 days prior to the onset of symptoms, so we take this into account when we perform contact tracing. The most frequent causes of death are respiratory failure in the form of acute respiratory distress syndrome, septic shock, and multi-organ failure. Therefore, in order to save lives, we need adequate intensive care facilities, equipment, and personnel. How does the virus spread? The primary route is respiratory, through droplets. Contact transmission through person-to-person touch is another important route, and we are learning more about aerosol and fomite transmission. This information tells us how we need to behave in order to prevent the spread of the virus. Stay at home if you are sick. Wear a mask. Wash your hands frequently. Ventilate indoor spaces. Clean and disinfect high-touch surfaces. This is a highly transmissible virus. It spreads very easily. We use a term called R0, or reproductive rate, to describe how many secondary cases will be infected by one infected person. At its peak in Korea, the R0 was perhaps 6 or 7. The R0 needs to drop below 1 before we can say that the disease is under control. The virus circulates and spreads efficiently in clusters such as hospitals, nursing homes, ships, churches, houses, and indoor environments where many people are sitting or standing close to each other, and especially where there is a lot of talking or singing going on. These places have been the targets of the virus and thus are the targets needing special protection. How much the virus spreads depends on factors related to the infected individual, such as how much shedding is going on, how much this person is moving around, how many people the infected person is meeting and how closely they are interacting. Also important are factors related to the setting, such as the number of people circulating in and out a contaminated area, the amount of ventilation there, and lastly, time. Time is of the essence because the quicker an infected person is isolated, the lower the volume of spread. Here is an early epidemiological graph of COVID-19 in China. I would like to draw your attention to the dates of the first 4 cases on the far left, December 1st and 10th. The alert was not sounded until December 31st. In other words, COVID-19 had at least 1 full month to circulate in Wuhan before they eventually started to address it. By the time Korea detected its first case, January 19th, China had roughly 2,000 cases and was well into its rapid escalation phase. In Korea, we see a similar graph. The first case was detected on January 19th, and the PCR test result came back positive on January 20th. We did not start our rapid escalation phase until February 19th, about 1 month later. But notice, the blue arrow indicates the day that patient number 31 first had a fever. The red arrows are the dates that she visited the Shincheonji church, spreading the infection. In Daegu, the caseload went from 1 to over 6,000 in merely 1 month. What this indicates is that the virus was circulating widely within the church and Daegu during the month of February, and the widespread testing, tipped off by the discovery of patient 31, then revealed the true extent of the spread. But now, after 3 months, we have most definitely crushed or flattened the curve in Korea. And as of April 22nd, we have had a total of 10,683 cases, 238 deaths, and thankfully, 8,213 patients have recovered and have been released from quarantine. There were 11 new cases reported over the last 24 hours, a far cry from our peak of 909 new patients per day on February 29th. So, how did Korea crush the curve? I would argue that it was not only what was done, but also how it was done that has led to the success of the battle so far. In terms of the medical response, it was methodical and rapidly adaptive. The non-medical response was just as important, and it was unified and well coordinated. The medical response included the tried and true epidemic infectious control measures of surveillance and early detection, tracking and tracing, testing, isolation, quarantine, triage, and treating. But Korea adapted to the unique challenges of COVID-19 and improved the traditional methods through innovation. Likewise, all branches of the government and the public, individuals, private corporations, and institutions really rose to the challenge of beating COVID-19. Let's take a step back and look at some of the ways that Korea was prepared for this type of pandemic. As a member of the WHO, Korea participates in the ongoing Global Influenza Program, which outlines how to deal with emerging acute respiratory diseases. Korea was not directly impacted significantly by SARS in 2003, but we saw how devastating a novel coronavirus could be in our neighboring Asian countries. During the 2009 H1N1 pandemic, Korea implemented many of the screening and testing procedures that are being used now. The MERS outbreak in 2015 was a game changer. As a result of the MERS outbreak, the framework for the IT and legal measures, for the surveillance at ports of entry and hospital entrances, for the screening and large-scale tracking and tracing, and for anticipating the non-medical societal impact of an infectious disease was put in place. With that in mind, Korea acted quickly to raise the alert level to level 1 a few days after the cluster of pneumonia of unknown cause was reported to the China National Health Commission on December 30th. Thereafter, the KCDC monitored the situation carefully, responded, and raised the alert level as needed. The first step was to bolster the quarantine measures at the ports of entry. Incheon International Airport is a major transportation hub, and fever detection technology and quarantine questionnaires were reassessed and fortified. Indeed, Korea's first patient was detected and quarantined at Incheon Airport, and as of April 22nd, 421 cases have been discovered through active quarantine measures. Now, there are about 70,000 airport employees, government workers, and military soldiers who are working round the clock at the airport to manage the import of COVID-19 cases. And due to their adherence to strict infectious control protocols, there has not been a single case of COVID-19 among the 70,000. The second step was to ramp up testing. In the beginning stages, Korea used kits that were supplied by the WHO, and the testing was done exclusively at the KCDC. Very quickly, first public, then private labs acquired testing capability. Korea had the fortune of having the KCDC conduct a tabletop exercise for an undetermined coronavirus back in December before the outbreak hit us. So we did have a bit of a head start. In other words, a blueprint for the type of testing that would be needed was drawn in advance. A SARS-CoV-2 specific RT-PCR test was developed by January 26, when we had only 3 positive cases, and by January 31st, it was distributed to local government labs across the country. Concomitantly, it was decided that emergency use approval should be granted to qualified testing products developed by Korean biotech companies. And by January 31st, when we still had only 7 positive cases total, a private Korean company called Kojin Biotech started to manufacture test kits domestically. As is known by many, the testing capacity was ramped up quickly to match the demand that was evident in Daegu, as hundreds of cases were diagnosed daily, and eventually we reached a maximum capacity to run 20,000 tests daily at over 118 testing sites throughout the country, including the world's first drive-through stations and walk-through facilities. To make this happen, we needed not only more kits, but more personnel, equipment, and transport logistics. And thus far, we have run a total of nearly 600,000 tests. This was a 24/7 operation. However, the success of the testing rests not just on its scale, but also on its targeted use. For example, in Daegu, preemptive screening of around 33,000 people at community service centers and nursing homes revealed 224 positive cases, thus effectively preventing further spread. Once a positive case was identified, the rapid tracing of contacts was essential. In Korea, the Ministry of Land, Infrastructure, and Transportation played an indispensable role in developing the technology that made the kind of massive and thorough tracking and tracing that we used possible. Mobile phone applications and a centralized platform that coordinated and computerized information gathered from epidemiology investigators, telecommunication and credit card companies, and CCTV data allowed contacts to be identified, classified, and notified quickly so that they could be managed appropriately. And the time and manpower that would have been required was dramatically reduced, for example, from 24 hours to less than 10 minutes. And the information was relayed to multiple agencies and even to the public almost in real time. Many people have raised the concern about infringement of privacy and restriction of freedom that these procedures have caused. These issues have been debated in our legislature, and the legal framework for providing the authority and enforcement of these infectious control procedures was outlined in the Infectious Disease Control and Prevention Act, which was first enacted in 1954 and was since revised in 2009 during H1N1, 2015 during MERS, and most recently last month during COVID-19. I would like to take a minute to read the first part of the law so that you can understand what is permitted. It states, if necessary to prevent infectious diseases and block the spread of infection, the Minister of Health and Welfare or the Director of the Korean Centers for Disease Control and Prevention may request public institutions, medical institutions, pharmacies, corporations, organizations, and individuals to provide information such as name, resident registration number, credit card transaction records, records of immigration control, and records of medical treatment concerning patients with an infectious disease and persons likely to be infected by an infectious disease. Once a person was tested and tracing revealed suspected cases, they were either placed under monitoring or quarantine, depending on their risk of having the disease. This process was facilitated by government employees who became case managers based at regional community health centers, and they distributed infection control materials such as masks, disposable thermometers, disinfectant, as well as food, financial support, and a copy of the guidelines that needed to be followed. The consequences of breaking quarantine or otherwise interrupting or obstructing the infectious control process have been communicated to the public. The guidelines were translated into more than a dozen languages, and a cell phone app was part of the IT that was used to monitor people under quarantine. Finally, appropriate triage and treatment were necessary to manage the tremendous surge in patients, to prevent death, and to keep the healthcare system from becoming overwhelmed and collapsing. Hospitals were designated as COVID-19 treatment facilities. Persons found to be positive were triaged or classified according to their medical condition and risk of deterioration, and they were assigned to an appropriate facility. If you recall, 80% of COVID-19 patients have either mild or moderate symptoms. They do not all need to be hospitalized. So patients with mild symptoms were isolated in facilities called living treatment centers, basically dormitories that were converted to monitoring facilities. Patients with mild COVID-19 were monitored twice daily, and if their condition worsened, quickly transferred to a hospital. Rather than permitting home self-isolation, Korea decided to isolate all positive cases in a facility in order to prevent secondary transmission to family members, since it was known from the WHO report on the situation in China that 78 to 85% of cases there occurred in family clusters. Also, we knew from experience that even patients with mild COVID-19 could decompensate suddenly, so a monitored facility was considered safer than home. The remaining moderate to severe or critical cases were immediately admitted to hospitals, either to sealed off general wards that were dedicated to COVID-19 patients, or if needed, a negative pressure intensive care room. The National Medical Center served as the control tower in directing the movements of patients so that the sickest patients could receive access to life-saving mechanical ventilators and high acuity care necessary for survival. A recently released study from China suggests that one of the reasons patients die of COVID-19 is because of lack of access to a ventilator. Aggressive triage and transfer using a national network of hospitals mitigates this risk. This table represents the different aspects of the medical response, and the middle square on the second row describes the temporary provision that allows for telemedicine. Since strict social distancing made going to a hospital difficult for simple medication refills, telephone medical encounters were allowed and were made billable. Also, a system for sending prescriptions remotely was established. As a clinician who is trained in the United States, it's my opinion that telemedicine is long overdue in Korea, but we will see what happens to this type of medical practice in Korea post-COVID-19. Escalation of the alert level to red, level 4, which happened on February 23rd, signaled the need to intensify and broaden the effort to combat COVID-19. As mentioned, a unified response at all levels was necessary, and unify it did. The medical response, led by the Korean Centers for Disease Control and Prevention and supported by the Ministry of Health and Welfare, involved public and private hospitals, local clinicians and labs, and the biomedical industry. The non-medical response involved the rest of the country. Every level of government directed its effort to support both the medical crisis and the non-medical parts of society that suffered the most, the economy and education. The participation of the public, however, was sine qua non, the most important component to effective control. In terms of the government's response, legal support was provided in the form of legislation that made massive tracking and tracing of contacts possible, and law enforcement helped to maintain order. Cybersecurity was also strengthened as more and more people spent time online for work, education, and daily household maintenance. Economic and financial support came in the form of an economic support bill of 11.7 trillion won, in addition to loans and financial assistance to small business owners and programs that waived or relieved debt, taxes, social insurance payment, and utility bills. Programs were developed to boost local businesses and stimulate domestic consumption. Since schools were physically closed, online learning was initiated, and internet and tech companies helped by donating tablets and services. The programs on the educational broadcast system were made data-free when accessed through their app. Seizing control of the supply chain of medical masks and constantly monitoring the inventory of critical personal protective equipment made it possible to safeguard Korea's healthcare workers, because there was a moment when failure to intervene would have made hospitals, doctors, and nurses vulnerable to infection, which would have led to disastrous results. Of course, the technological support provided by the Ministry of Land, Infrastructure, and Transportation facilitated the gargantuan task of tracking and tracing each case. And the Ministry of Foreign Affairs carefully navigated the situation with regards to controlling both the inflow and outflow of potential positive cases by implementing travel restrictions and special procedures while keeping channels of diplomacy and dialogue open between nations. I should add that helping your allies through their times of distress not only strengthens the bonds in the spirit of global solidarity, but also shows maturity and foresight. And from an infectious disease pandemic standpoint, helping struggling countries is one of the best ways to protect your own homeland, since these types of diseases tend to circulate the globe more than once before eventually quieting down. Businesses and livelihoods were on the brink of collapsing, and the government's major economic measures against COVID-19 prevented this from happening and gave the public reassurance that there would be solutions to the financial burdens of the pandemic. This relieved much of the stress and anxiety that filled people's minds and made it easier for everyone to follow the social distancing policies that prevented COVID-19 from getting out of control. Yes, it was critical that the public be fully on board. The public awareness campaign was successful because the messaging to the public was widespread, almost to the point of being unavoidable. It was easy to understand, transparent, timely, and it was updated as needed as the situation evolved. Also important was the early effort to combat the infodemic, the spread of misinformation that only serves to confuse the public and disperse the focus from the true enemy, COVID-19. The result was a high level of trust in the government's actions, and this translated into better compliance. Director Jung Eun-kyung of the Korean Centers of Disease Control and Prevention is my hero. Through her press conferences, she has been a steady, wise, and patient voice, informing and guiding this country during this difficult time. I have nothing but praise and heartfelt thanks for her leadership during Korea's battle against COVID-19. All in all, this massive countrywide effort allowed South Korea to crush the curve without resorting to a strict nationwide lockdown. COVID-19's impact on society has been colossal, the loss of life tragic, and battling this deadly, cunning, and invisible enemy has caused exhaustion, frustration, and grief. Nonetheless, we have overcome at least the first round of this challenge. But the story is far from over. there are many issues that are still unresolved. What are the causes and the consequences of the virologically cured cases that have mysteriously converted back from PCR negative to PCR positive status? The world eagerly awaits the results of the upcoming Inovio Pharmaceuticals COVID-19 candidate vaccine trial to be held here in Korea. There have also been clinical trials of repurposed medications performed in Korean hospitals. We await those results in addition to news of a potentially newly developed cure, such as antibody-based treatment. Pooled sampling of asymptomatic, high-risk populations will add another layer of security, and community-based antibody studies will give us a clearer idea of how extensively COVID-19 has actually penetrated into society. There is news of creating a hospital dedicated exclusively to the treatment of infectious diseases here in Korea. And as we all breathe small sighs of relief with the significantly lower numbers of daily new cases, consistently less than 20, we should understand that the threat of a second wave is ever lurking if we are not careful. So faster point-of-care diagnostics need to be developed now. When and how do we further ease the social distancing measures and reopen schools? And of course, are we ready for the inevitable next epidemic or pandemic? I would like to take a moment to acknowledge the very important people who helped me make this presentation. Professor Woo Jung-yup coordinated this lecture, and Ms. Ji-won Jung helped me with the research. I would like to thank the Ministry of Foreign Affairs and the Ministry of Land, Infrastructure, and Transportation for allowing me to use their materials in this presentation. As a resident of South Korea, I would like to thank, from the bottom of my heart, the Korean CDC and the frontline healthcare workers who have been working ceaselessly, tirelessly to keep us safe. Finally, the last 100 days have been very stressful and difficult psychologically for a lot of people, including myself. So I would like to say thank you to my family and friends who have been supportive and encouraged me to follow and report on the events of COVID-19. Last night, I saw the press conference of Governor Larry Hogan, the governor of Maryland. He and the First Lady coordinated Operation Enduring Friendship, in which the capacity to test 500,000 people using Korean-manufactured COVID-19 test kits was delivered by Korean Airlines directly to his state. I hope that this type of cooperation and effort will be the enduring legacy of South Korea's battle against COVID-19. That we worked hard to keep not only our country safe, but also contributed to the safety of the world during this, the greatest challenge of our generation. Thank you very much for your kind attention, and please stay safe.